Well, thank you very much, Representatives. I thought that was a very productive discussion, and I know I learned a lot, so that was super. Next, we're opening the hearing for public comments. So I'd ask if you have a comment to please identify yourself first, and then be good. Sure.
Advanced benefit design. I really and truly believe in mental health care, but I just want to point out that, many years ago, I had to see a counselor for a rape crisis, and my insurance company gave me 6 initial visits. And I went to a counselor, and the first visit he told me all about Volvos and all about different cars and things like that. The second visit, we spoke about microwaves. And what was interesting is, of the 6 visits, nothing was really accomplished on those 6 visits. And I believe that if you have mental health parity, which basically says, hey, sky's the limit, you can have unlimited visits, you need that insurance company checking in after 6 visits, after 10 visits, to make sure that the person is getting the help that they need. Because people with mental health issues are very vulnerable, and they can be easily taken advantage of. And because of HIPAA, you can't ask any questions. Okay, I can't ask my daughter, hey, what did you talk about? She's not going to tell me. Okay, it's very important to have a system of checks and balances so that bad people don't do bad things to good people. Okay, because there are very good providers out there, but there are also very bad providers out there, and there needs to be that system of checks and balances.
Thank you very much.
Linda Zielinski, I'm with the Department of Insurance, but I've actually had a conversation like this with a friend of mine who's an APRN, and he's in mental health counseling. And the way he explained it to me was, a psychiatrist has to go through medical school just like any other doctor, and then he has to specialize just like a surgeon or, things like that. So he is part of the medical profession. An APRN has to go through the same things that an APRN that works for your primary care doctor goes through. So they're part of the medical profession. They should be paid the same as a doctor with their same qualifications. If you go through medical school and then specialize, it doesn't matter what your specialty is. Obviously a surgeon does something different, but the costs need to be comparable, or how they are paid needs to be comparable. My friend said, right now, New Hampshire is in a crisis. We need a lot of mental health counselors and psychiatrists, and they're all leaving the state because they are not being paid enough. They can go to New York or to Boston or to California, and they're getting paid a whole lot more. And he said, very soon, we're not going to have the proper counselors and psychiatrists that we need in this state. And then how is the legislature going to handle that? You have to address that before it becomes a crisis.
Thank you, Linda. Anyone else?
Brian Marabella, I'm an independent insurance broker with Health Apply. For the DOI as well as the policymakers in the room, one of the things we've started seeing recently is our Medicaid population that have substance abuse issues, as they go back to work, start getting their lives back together, and lose their Medicaid benefits because they now have income, the difference between how the state requires Medicaid to cover treatment versus how we do or don't require the insurance companies to cover treatment is potentially going to be an issue in the future. We've got people that are accustomed to getting injections that they go in, they get their treatment. Now they're moving on to private insurance. It's not the same, it's not covered the same. And we're going to start tracking to see how many of our dependent clients drop insurance after a month or two when they realize they're not going to get the same treatment that they're accustomed to. I think that is going to work backwards with what we have for an opioid crisis and trying to get the Medicaid population back to work and contributing to society, but we're going to change their treatment schedule or the way that we want them to be treated once they're on the private side.
Thank you.
Keep in mind and keep your eye open for.
Absolutely.
Hi, Ken Norton from NAMI, New Hampshire, the National Alliance on Mental Illness, and I have several comments. First is to thank the Insurance Department for this public hearing and for the advisory council that has been established. And I think that advisory council has been very helpful at bringing together advocates, providers, and insurers to have these conversations. Also would want to acknowledge that that came about through legislation that was introduced by Senator Dan Feltus, and thank him for that. If nothing else that I say lands with people in terms of importance, the number one thing that I would like to say relative to this conversation is that the National Institute of Mental Health has identified that people with serious mental illness die 25 years before their peers in the general public. And there's a number of reasons for that, one of which Dr. Frank identified as the co-occurrence of serious mental illness with medical conditions, but that should be our starting point about what we're trying to accomplish when we're looking at mental health care and parity, is to level that off, because the level of care and the access to care that people have is not the same in my experience as a family member and as a provider as people in the general population. As we look out towards the future, there are a number of treatments where there are evidence-based and specifically looking at early intervention for serious mental illness like schizophrenia, first episode psychosis, early serious mental illness that have what's considered coordinated specialty care, and these go beyond typical medication and medication monitoring and psychotherapy, and include educational supports, vocational supports, home-based services, family education, again, those psychosocial pieces that have been talked about. And the evidence indicates that, that this comprehensive treatment is very effective at reducing the overall cost and burden of these illnesses, but they're difficult to pay for. So our commercial insurer is going to start looking beyond the typical medical interventions and the overall costs. And that's likewise with the system of care that's being established for children in the state, home-based services that are part of that program. And then relative to access to care, I would say the most frequent call that NAMI New Hampshire gets to our information and resource line is from people who are unable to access outpatient treatment. And there are many reasons for that, but what we often hear is that they're given a list of providers by their insurance company. They call all of those providers, and they're told for a variety of reasons that those providers are not accepting new clients. And so a term that we've come to dub as ghost networks, where they really aren't networks that are accepting new people. And an additional complicating factor to that is that we're hearing from providers that they're hiring staff, that they are getting these calls and referrals, but they're not able to get their providers credentialed through the insurance companies. These are people that may be licensed in the state, but they're not able to get them impaneled. So I think another important area that needs to be addressed. And then, as was also mentioned, that that a number of providers are only accepting cash because the administrative burdens of trying to deal with insurance companies are so difficult that that they have enough referrals that they can just say, I'm not going to deal with it. I'm only going to accept cash payments, and that limits many people from accessing the care that they need or the providers that might be able to serve them. And then I want to note that as many people have heard me talk about, the emergency department boarding crisis in our state. That's a significant issue. During the course of this week, we've been averaging in the 30s a number of people waiting for inpatient care. And while the bulk of them have Medicare or Medicaid or no insurance, on any typical day, there is a handful or more that have commercial insurance. And the availability of inpatient care in our state, inpatient psychiatric care, has decreased dramatically over the last several decades. And with it has also decreased the step-up and step-down services like intensive outpatient or other programs that might prevent the hospitalization or allow for a more rapid discharge from the hospital. And that continues to be a major area of concern. And then also want to talk about that through our integrated delivery networks and/or the change that that has been mentioned by several people today, we're looking at much more integrated care. I think that there's general agreement that the segregated system of mental health care in our country has not necessarily been effective, and we need to look at the whole person. And yet there's still significant barriers to paying for integrated care. And as we move towards that integrated care system, we need to figure out how to remove those barriers so that people can get the care that they need. And that includes non-traditional treatment that might be complementary, such as yoga or acupuncture or other things. I mean, the Veterans Administration has successfully used yoga with severe PTSD. I mean, how do these other typically non-traditional services weigh in? So thanks for the opportunity to offer my input. Yeah.
Great comments, Ken. Thank you. Yes?
Holly Stevens from New Futures. I wanted to echo much of what Ken said, but I also wanted to bring up, in addition to, maybe somebody who's in network hiring additional staff, clinicians, I've heard from clinicians that are not in network that they are being told by the insurance companies when they try to get in network, our networks are adequate, we are not going to add any more practitioners or clinicians, behavioral health clinicians. However, what they're finding is people are calling them and saying, I have called everybody on a list for my insurance company, nobody is taking patients, I don't know what to do. And it's one of those things where, when the clinician says that to me, who do I direct them to? Because, they're saying the big commercial insurers, the Income, Cigna, Harvard Pilgrim, are telling them their networks are adequate, but the networks do not have any clinicians that are accepting patients.
Anybody else?
Speaking as a large commercial insurer, I would want to know that. We don't have a closed network, so if people are having that struggle, I would want to know. So.
Something else? Doctor?
I guess I would echo, as somebody who runs Harvard Pilgrim in New Hampshire, I would echo that same, we want as many providers in as want to get in with us. So if there's problems with access, whatever, I can't fix it if I don't know. We do regular surveys to make sure people can get in, but if you have information, get it.
Absolutely. Thank you.
I think past efforts at trying, the department did a really good outreach session with employers and others about some of the barriers, and I don't think it's the fault of the insurance companies, but it's still very difficult for consumers to understand who's in the network, because you have to do, and we still need to work on figuring out how to make it more accessible for consumers to understand who is actually in the network and who's accepting new patients. There's been a lot of progress on it, but I think it's still an ongoing issue, especially on the individual market, where they don't have as ready access to navigators or brokers, maybe.
Sure.
I just want to add that if anyone has a complaint, we accept provider complaints and consumer complaints through our consumer services division at the insurance department. There's some materials out there that have the phone number and the email address for them. If there's a specific consumer involved, then that's something that we can help with. And it's always helpful for us to be aware of trends, even if there isn't something that we can, do specifically in that moment. So please, if you have feedback, share it with us, because sometimes we don't know until we hear from all of you. So.
Just one other question. There's just a huge talk across the country by all kinds of providers about prior authorization processes, and I just don't know if the department has any intention to host any kind of convening around the different impact that it has on different parts of our system.
We haven't had a lot of discussion about that, but it's definitely a very important topic that we would absolutely consider. So I'll be working with Tyler and others on seeing what we can do there. Appreciate the comment. Yes.
For the carriers in the room, I might suggest that you have a concierge service for mental health, in that, when someone calls, that the carrier takes their hand, gets them the appointment, makes the appointment for them, follows up with them, and helps them. Because I think when they have a sickness, that carriers do assign caseworkers to them to help them.
Just, again, Bill Brewster from Harvard Pilgrim, just to follow up on that. We have a guaranteed network where we have mental health providers who guarantee to see people within a matter of days. And if I say the number, it's going to be wrong, with 5 or 6. But we have that. If you call the back of the card, if you're having difficulty for whatever reason, if they ask for that, we have docs who will guarantee to get people in within a fairly short period of time.
Thank you. Anyone else? Excellent. Well, thank you, everybody, for attending. As you can see up here, we'll accept written comments through November 12th, and Ariane will be receiving those, and her contact information is up there. We'll also be sending out a survey. Please give it some thought, because we always want to improve what we do every year, so that'd be wonderful. And I'm sure there's going to be a couple food comments on there, and it's well-deserved. So thank you all again.